to our next presentations. I would like to introduce our speakers, Dr. Tho Pham and Dr. Kelly Kronsberg. Dr. Pham and Dr. Kronsberg currently serves as an antimicrobial stewardship and resistant expert at the Arizona Department of Health Services, and they will be talking about ADHS initiatives to enhance antimicrobial stewardship. Dr. Pham and Dr. Kronsberg, please take it away.
Thank you, Rachana, for that introduction. Okay, and so let's go ahead and kick things off. So Tho and I will be discussing updates on ADHS initiatives to enhance antimicrobial stewardship. So I know Juliana and Celine just gave a fantastic talk about multi-drug resistant organisms in the state of Arizona. I'm not even going to attempt to repeat all of that, nor would that be a good use of our time. But just to bring it right back to your memory, we're seeing increases in MDROs in the state of Arizona, and that's going to apply to carbapenem-resistant Enterobacterales, Candida auris, Acinetobacter baumannii, as well as Pseudomonas. And when we look at the context of the nation for the 2023 carbapenem-resistant Enterobacterales rates, we see Arizona, Nevada, and not pictured, but Puerto Rico also leading the way in the rates. This is very important for us to be discussing in the state of Arizona. A larger national perspective, the most recent data that we have is comparing 2019 to 2022, which is highlighted on the right side of this table, where over this period of time, which was the COVID pandemic, we see increases in hospital onset carbapenem-resistant Enterobacterales, carbapenem-resistant Acinetobacter, Candida auris, vancomycin-resistant Enterococcus, ESBL-producing Enterobacterales, and multi-drug-resistant Pseudomonas aeruginosa. We did stay stable on MRSA, so we'll take that as a little bit of a win where we can, but overall, really driving home the point that antimicrobial resistance is concerning, which I know everyone on this call is aware of because you're prioritizing attending our webinars today. And it's tempting to just talk about this in terms of the numbers and the incidence and the bacteria, which is how we tend to frame a lot of our discussions around antimicrobial resistance. But we wanted to pause and emphasize that these aren't numbers, these aren't just bacteria, these are patients who are affected. And this is something that the Infectious Diseases Society of America, as well as the World Health Organization, has really emphasized putting faces behind AMR, because the pandemic for AMR might be more silent, but these patients really shouldn't be. So we need to be mindful of that because they're really our priority at the end of the day. Now, when we want to address antimicrobial resistance, there's three main pillars that I think of. The first being surveillance, which Juliana and Celine just covered wonderfully. The second being infection prevention, which they also touched on. And the third being antimicrobial stewardship, which is of course going to be mine and Tho's focus for the next hour. So what is antimicrobial stewardship? In short, it's really optimizing the use of antimicrobials, ensuring that each patient is evaluated so that they receive the right agent at the right dose via the right route for the right duration. And the goals of this are really multifaceted. At the top, like I mentioned, our focus is really on the patients, what's going to be optimal for their care, and balancing treating the infection while minimizing adverse events and other risks, such as development of Clostridioides difficile associated diarrhea or future organism resistance. And along with that, reducing the morbidity and mortality, as I touched on, and really optimizing resources across the continuum of care. And a lot of times, stewardship programs are held at the local level, perhaps the facility, and this is where public health can come into play, connecting different aspects of that continuum of care to help facilitate communication, like that transfer form that we were just discussing. And I want to emphasize that this isn't something that we can do in the public health arena alone or as pharmacists alone. It's really going to take everyone, providers, microbiologists, veterinarians, epidemiologists, and not only public health, but acute care and long-term care and all these different settings that Tho and I will be talking about today, and just emphasizing that this is really a team activity and we need to work together to achieve this goal. but these goals can be pretty lofty. And we can't just target 100% right off the bat. That would be kind of disheartening to consistently fall short. So realistically, stewardship programs, or even us in the public health setting, need to set smaller, more achievable, SMART goals that ultimately point us to this goal of antimicrobial stewardship, reduction of resistance, and this slide is just to emphasize, as I mentioned, the health departments connecting emergency departments, urgent cares, outpatient clinics, dental practices, hospital, term cares, as well as veterinary and agricultural partners, which is something that ADHS is looking a little bit more into with some of our One Health initiatives. So then comes the question, what are we doing in terms of antimicrobial stewardship? And I'd like to kick that off talking about our Arizona Antimicrobial Stewardship Subcommittee. So this is a 98-member committee that consists of pharmacists, providers, microbiologists, epidemiologists, and other interested parties. We meet quarterly to discuss different data as well as potential solutions and ideas. So we'll go over multi-drug resistant organism data, usually Juliana or Celine presenting that, as they did a fantastic job. If we conduct a survey, we'll be discussing some of those results. You'll be hearing about that later in our presentation. We also will analyze the data available to us within the National Healthcare Safety Network, or NHSN, and create findings there, which we'll also be talking about later. And we'll also solicit some practice pearls from our expert members. So this is a really well-attended and engaged committee that you'll be a co-chair of. One of our initiatives that we've been working on this year is an office hours series. And this is open to all healthcare professionals and health departments. It's held every other month on even months. And we actually did record all of the sessions, and those session recordings, as well as materials such as slide decks or handouts, are currently available on our website. So our first 4 for the year, to give you an idea of the topics, were the use of interviews to delabel penicillin allergies, diagnostic stewardship for asymptomatic bacteriuria, as well as the antibiotics' impact on the human microbiome and the effects that can have past just Clostridioides difficile infections, as well as blood culture stewardship. Now, our October session was delayed because our speakers are from the CDC, but we actually just got this rescheduled yesterday, so it'll be held December 3rd, and they'll be talking about Candida auris, such as national trends, changes in case counts, epidemiology, antifungal resistance, along with a refresher on precautions, screening, and treatment. So we're very excited for these experts to come and talk to us, especially, as I pointed out, Candida auris rising in the state of Arizona, and Celine had touched on that as well. Our formal December session will be held by Dr. David Nix, who will be discussing the antibiotic combination of piperacillin and tazobactam and vancomycin. For those who aren't aware, this has been a clinical controversy due to mixed data regarding the incidence of acute kidney injury when this combination is utilized. So he's going to be discussing some of that data and teasing out why we aren't seeing consistent results. This should be a great one. And then lastly, to kind of wrap up what I'd like to cover about our office hours is that we do have a Google form where we really encourage people to submit what topics or speakers they would like to hear from within this series, and this is also available on our website. Moving on to, the setting where we might think about carbapenem-resistant organisms or multi-drug resistant organisms or antimicrobial stewardship the most, acute care hospitals. So the CDC has core elements for antibiotic stewardship, and they consist of 7 core elements. And those are leadership, accountability, expertise, usually pharmacy or stewardship expertise more specifically, action, tracking, reporting, and education. And if we look at the foundational requirements of meeting one component within each element, we see we do pretty well in the state of Arizona, generally over 90% for each element and comparable to what we're seeing nationally. So that's great, but maybe this bar is a little too low for where we're at right now based on these numbers. So the CDC also proposed priority core elements, which takes it to the next level, and has a specific definition that needs to be met for each core element. So for leadership commitment, the program leader should have stewardship responsibilities in their contract, job description, or performance review. For accountability, the program should be co-led by a physician or a pharmacist, with the exception that critical access hospital programs may be physician-led only, recognizing the resource limitations in those settings. For stewardship or pharmacy expertise, the program leaders should have completed infectious diseases specialty training, a certificate program, or other training on antibiotic stewardship. And for action, the program should have facility-specific treatment recommendations for common clinical conditions, as well as performing either prospective audit and feedback or pre-authorization. For tracking, the hospital should be submitting data to the NHSN antimicrobial use option, and for reporting, generating antibiotic use reports that are provided at least annually to target feedback to providers. In addition, the program should monitor adherence to recommendations for at least one clinical condition. So let's see how we're looking for those. And within NHSN, there's a survey that is completed annually. So we are looking at the 2024 survey results as those were completed at the beginning of 2025. So we had 92 facilities complete the survey, 66 of which were general acute care hospitals, 15 were critical access hospitals, and 11 were other acute care hospitals. So facilities in this category may be psychiatric institutions or surgery centers rather than general hospitals. And when we did this analysis, we described each core element for the state of Arizona as a whole, as well as by facility type. But I'm just going to give you a very brief overview for the sake of time and tell you that out of all 6 of those core elements that I went through, we had 4 facilities, or 4%, meet all of them for 2024. So this is a stark difference compared to when we look at the general core elements. However, for 5 out of 6, we did have 23% of our facilities meet 5. So where are we seeing our strengths and our areas for opportunity? Now, taking action is actually the highest one that we see, where reporting is the lowest at 22%. And we see leadership commitment and tracking kind of in the middle, expertise and accountability a little bit higher. So obviously the next question is, what are we doing with this? Well, we're going to start out with an email outreach to participating facilities. We're going to include resources on how they can fulfill the priority core elements, as well as ask if they want to tell us about what barriers to implementation they're experiencing or opportunities for ADHS assistance. We're also going to offer a future virtual session for interested facilities to join, where the core elements, this analysis, and implementation strategies will be discussed. And this may also feature a presentation or two from the facilities who met all 6 core elements. And we talked about reporting being really the area of improvement that was identified here. And one of the things that ADHS has coming out soon is we will be sending out facility-specific NHSN AU reports. So I'm going to take a few moments to explain what these will consist of, because they should be coming out in the next month or two. And by explaining what a SAR is, and that stands for Standardized Antimicrobial Administration Ratio. And essentially, the NHSN gathered baseline data a few years back. What sort of things in a facility predict antimicrobial use and how much can be expected? So this might consist of things like the number of days of patient stays in the facility, the number of ICU beds, the teaching status, and ultimately they've created a predictive score where they can anticipate how many days of antimicrobial therapy they would anticipate the facility using. And this is a ratio, so ultimately, for their actual antimicrobial use, that is compared to the predicted. So a SAR of 1 means the actual use equals predicted use. A SAR of greater than 1 means the actual use exceeds predicted use. And then conversely, a SAR less than 1 means the actual use is less than predicted use. So in this graph on the left, we have SAR along the x-axis and number of hospitals along the y-axis. This is going to be a statewide comparison, but we recognize that different size facilities may have different resources. So we have divided our hospitals into either being small, medium, or large groups. And for this specific example, this is a facility within the medium hospital group that is showing an overall antibacterial agent SAR of 0.8. So their actual use is a little bit lower than their predictive. And it's important to call out that this cannot determine whether the antimicrobial use is appropriate or not. That's going to need to be a facility level patient-specific probably evaluation of the appropriateness. But if I was the facility that had that SAR of 2.8 as an outlier, that would trigger to me that I should be looking at my patients and more thoroughly evaluating if that use is truly indicated. And maybe it is at that facility. Maybe they have some unique considerations and a high infectious rate, but it should trigger a little bit further investigation is ultimately the goal. In the graph on the right, we have SAR on the y-axis this time, and it shows trends over time. So this allows the facility to also compare to facilities of a similar size as well as our statewide average. And we do have error bars on this so that you can also determine if the difference is statistically significant or not. So in this example, the hospital is using a below average SAR, and that's pretty consistent, although it has been increasing over the past year, is what we can see from this data. Now we're going to include one other analysis in this report, and that's going to be a ranking system because we've gotten the feedback that facilities enjoy kind of a ranking system, and especially when they're successful, hearing that they're the best, right? That's always the goal at the facility level. And so along the top, we'll have what the facility SAR is, a statewide comparison, and then what that rank is. And for these rankings, a lower SAR will always be considered better, recognizing that this may or may not be factual in real life, and perhaps not all SARs really should be considered that way, but we needed to determine a way to rank them for consistency, and overall that should be the general thought process. That's what we went with. And then in the second table, there's also going to be comparisons to facilities of a similar size. So that will also provide a ranking. And then in the last, there will be a 4-star system where the top 25% of facilities in the ranking will receive 4 stars, the top then 26 to 50% will receive 3, and so on and so forth. I also wanted to call out that ADHS has put toolkits together to assist facilities. So on the inpatient setting, we do have an antibiogram toolkit, and we are also working on a Clostridioides difficile toolkit. It's in the final stages of leadership review, and this is going to consist of sections such as infection prevention, surveillance, clinical management, and reporting. So hopefully this is coming out in the near future. I'm going to shift over from acute care to long-term care. And I especially wanted to call out this setting because when we look at a national level of percent positivity out of total cultures, we actually see that long-term acute care hospitals have the highest percentage of carbapenem-resistant Enterobacterales out of all the cultures they send. Now, by the numbers, general acute care hospitals do have the most numerically, but by percentage of their total cultures, they're actually a little bit lower. So this is an area that we want to focus on, and they may have less resources than the acute care hospitals as well. So let's start things off looking at the same core elements that we talked about in the acute care setting. And for this, we're looking at 2023 data where we had 31 facilities complete the survey. And we can see for the individual core elements, we're generally 90% or higher, and with about 81% meeting all 7 and 90% meeting 6. So I'd say we're doing okay here, some areas for opportunity, but none that are standing out very starkly, in my opinion. We also have toolkits for the long-term care setting. So this may include suspected urinary tract infections, skin and soft tissue infections, as well as respiratory infections. We go over some brief diagnoses, although obviously clinical judgment is going to be what leads the way there, as well as some treatment options. And if there's any other considerations, such as common myths around particularly interpretation of urinalysis or symptoms of a urinary tract infection, those are all addressed in here, and these are available on our website. I also wanted to call out that we have a long-term care subcommittee similar to our stewardship subcommittee for the state of Arizona. And what I have highlighted here is that at every meeting we provide stewardship updates. So this is one of the ways that we perform outreach to these facilities at a state level is through these meetings. And then, of course, education is also going to be a cornerstone. So for here, I wanted to discuss a continuing education presentation that Toe and I gave in September to the Arizona State Association of Physician Assistants. And we talked about the management of asymptomatic bacteriuria and candiduria, since we know things like altered mental status can be more common in the elderly population, especially those in healthcare facilities, as well as the fact that asymptomatic bacteriuria incidence increases with age. So this was something that we had a great conversation about, and we're able to discuss some of the signs or myths that are historically associated with UTIs that don't really pan out in the evidence and how to apply evidence-based care. This was a great opportunity, and we're looking forward to continuing our partnership with this organization. And then last area that I'm going to talk about are our dialysis centers. So we conducted a survey in 2024 looking at antimicrobial stewardship practices in dialysis centers. And I pulled a few of the results out of it that interested me the most. We had 49 facilities participate, and it's great that 75% of them said that they have someone designated to evaluate antibiotic trends. But then we dropped down below 50% for those who have a formal stewardship program, those who assess anti-infective dosing for appropriateness, which hurts my pharmacist heart a little bit. Though less than half ensure that the antibiotic ordered is appropriate for the pathogen. Less than half evaluate duration of therapy. Just over a third discontinue antibiotics if there's no signs of infection, and only a third de-escalate antibiotic therapy, such as from MRSA to MSSA coverage, depending on the culture. So I'd say that this identified several areas of opportunity. But what did we do with this information? Well, we also have an Arizona end-stage renal disease subcommittee, which is somewhere else that we discuss antimicrobial stewardship at and perform outreach. And one of the things that came up was communication from the acute care setting for patients who need to continue receiving antibiotics after dialysis in the dialysis centers. So we highlighted the CDC interfacility infection control transfer form, as well as the ADHS transfer form. And then, of course, we discussed the findings of this survey, as well as the NHSN annual practices survey, because that tells us a little bit more about culturing and how these centers are managing suspected bloodstream infections, as well as a more in-depth review of the data from NHSN around dialysis-associated intravenous antibiotic starts for potential bloodstream infections. And just to pause for a moment on that, when we performed that review, we found that up to 63% of courses were potentially inappropriate. So we discussed all of that in conjunction with the CDC, and ultimately, the next step that we believe is best to take is to work with our dialysis centers around the state of Arizona and ensure the accuracy of what we're seeing at NHSN, because some of those numbers are concerning, but we need to ensure that it's accurate before we take further steps and build those partnerships and collaborations in order to move forward. So that is our current plan in the dialysis setting. And with that, I will hand things over to Toe to discuss the remainder of the settings that we are taking action in for antimicrobial stewardship at ADHS and wrap things up for the day, or for our talk at least.
All right. Thank you, Kelly, for sharing our fantastic achievement in, the important inpatient long-term care and also hemodialysis. And you definitely set the bar very high. But right now, let's switch our gear to go into the outpatient setting, including dental. Okay. So the foundation of our entire outpatient strategy is with robust data, like Kelly has mentioned as well, Juliana and Celine. We believe that we cannot act on what we cannot measure. So we started by conducting a comprehensive 5 years analysis of all outpatients antibiotic claims from the CMS Medicare Part D data sets. We analyzed this data as two different levels, the provider level to see who was prescribing and a drug level to see what they are prescribing. And this really gave us an incredibly granular view of prescribing pattern across the states. And after excluding the low volume prescriber, we ensured that our data was statistically significant, that we were left with a powerful 5 years data sets. And what is told us was very fascinating. So here is the first level look at our prescribing rate per 1,000 beneficiaries broken down by drug class. So this table tells us two very different stories. First, the win. Look at the fluoroquinolones. We saw a consistent 5 years decline, resulting in about 6% overall drop. This is a fantastic stewardship success and a testament to years of national and local stewardship messaging. But this data also immediately uncover our next challenge. Let's look at the penicillin up by 22% and the cephalosporin up to 10%. So this told us that while we've been successful in discouraging one class and the prescribing practice has shifted. So this data allow us to pivot our strategy to be more specific in our messaging. Let's ensure the right drug for the right duration and as well as for the right indications. Next, we wanted to understand who was driving these prescriptions. We segmented our prescriber into lower volume and higher volume group. The higher volume group is defined as those prescribed the top 10 percentile in the volume of antibiotic prescriptions. What you see here is that consistently over 5 years, from 2018 to 2022, about 39% of all prescriptions come from that higher volume group. And so this was a critical finding because it shows us that a significant portion of our antibiotic use was concentrated in a very specific group of prescriber. And this is the slide that truly give us a more zoned in, clear view. The higher volume group doesn't just prescribe more. They prescribe at a dramatically higher rate, but even more importantly, look at the trend. The gap is widening. In 2018, the difference in the prescribing rate was about 40%, but by 2022, it had jumped to 55%. So what it's telling us from the graph is the one-size-fits-all educational strategy simply would not work. To make the real impact, we had to find a way to focus our limited resources and engage a specific high-volume group. So our next logical question was, who is in this high volume group? And the answer was stunning. We stratified this group based on the medical specialties, and one profession emerged as a clear and significant outlier, and that's going to be our dentist. With a mean prescribing rate over 1,000 prescriptions per 1,000 beneficiary, they are prescribing at nearly twice the rate of the next closest specialties, such as urologist. And additionally, look at the trend line over the 5 years. It remained pretty flat. While other specialties have seen some modest stewardship-driven decline, the dental antibiotic prescribing has remained pretty consistently and stubbornly high. So this data was a call to action. It gave us a data-driven mandate to build a bridge to our state dental community. But before we do that, we also want to know more about our facility, right? So we had our what from our CMS data, now we needed the why. We had to understand that what the on-the-ground barrier that our outpatients partner are facing daily. So to do this, we launched our very own Arizona Outpatient Antimicrobial Stewardship Survey to hear directly from our clinics and clinicians. So this is a completely confidential survey, and we did reach out to all our partner and key stakeholders to maximize facility outreach. So we are thrilled to get over 200 responses among more than 200 outpatient facility, and the results were incredibly insightful. On the left side of the slide, we surveyed the uptake percentage across 4 outpatient core elements, and for leadership and education, you can see that we broke it down further into smaller component. We saw a real strength among our Arizona outpatient facility, with over 70% reported have policy and actions in place. So this is pretty consistent with our acute care partners. But we also saw a clear actionable gap that was faced by our outpatient facility, is that education to patients was the lowest ranked element. On the right side of the slide, we're now looking at how many facilities currently implement all 4 core elements versus 3 core elements and versus 2 or fewer core elements. And most tellingly, in that orange box, less than a third of our outpatient facility report implementing all 4 of the CDC core elements. So this told us a story that our partners are not starting from scratch, and that they are trying and they have the pieces in place, but they need help from us to connect these pieces together into a comprehensive and sustainable stewardship initiatives. And that survey data was further reinforced by what our partner told us in their own words, hearing from the verbatim quotes. We heard about the struggle for leadership commitment from our patient partners. We heard about the intense pressure from the patients. We heard about the unique challenges in our rural community that they have to prescribe some sort of antibiotic so that our patient can have on the shelf due to the distance of driving to the closest care. We also hear loud and clear about the conflicting pressure from other guidelines like the sepsis bundle. But then our facility also told us that they don't just need the data, they need the support, the resources, and most of all, they need help managing the patient expectations. So that's where we step in as a state level and we listen and we acted. Our next step is a direct response to that data, show that what our partners has told us. We heard a call for local resistant data, so now we're actively soliciting microbiology data to build our first ever state level, maybe potentially regional level for outpatient antibiogram. We also heard the need to help with the patient educations. So we immediately provided CDC resources and more importantly, asked them, is this enough? Do you need more of the ADHS or Arizona Pacific material? And finally, we took the dental data and provided data and launched a deep ongoing collaborations with our professional society to provide a continuing education and build stewardship champion within their own organizations. And this is what the support looks like in practice. And then I am incredibly proud of our team for developing this comprehensive one-page outpatient toolkit to cover the most commonly seen infections in outpatient care. And these guys are easy to use and they are available right now on our website for any provider in our state to use. And as you recall, our outpatient data analysis gave us our what. So now we want to show you what we did with the information. And this is our deep dive into our dental setting. As a quick reminder, this is our call to action slide. Our CMS Part D data analysis had showed that consistently with what we've been seeing in the country, Arizona dentists, the top blue line, prescribe at the rate over 1,000 prescription per 1,000 beneficiary. That's like almost like every person who gets seen by a dentist will come home with at least one antibiotic prescription. And critically, that line is remain flat. So this data has told us an additional story that we could not make a meaningful impact on our patient stewardship without a dedicated, respectful, and collaborative partnership with our dental community. But to do that, our first step is to understand what was being prescribed. The top 5 here listed are not surprising. Amoxicillin is appropriately number 1, but I want to draw your attention to number 4, clindamycin. And as a stewardship pharmacist, seeing clindamycin still being the top 5 agents in any setting, particularly for dental setting, is a significant red flag because we all know here that it's a major driver for C. difficile colitis, and this told us we had a clear education target. We then compare Arizona dentist prescribing pattern for these top 5 drugs to the national average, and we have found that this is not just an Arizona problem. The trends are nearly identical between our state and also for the national states. And you can see the persistent high volume prescribing of amoxicillin and penicillin VK, and as well as the stable line for clindamycin use over the past 5 years. And this confirmed that the problem was systemic and our intervention needed to be more robust. But the drug class is only telling us half the story, the duration which is critical. We analyzed the average day supply and we found another critical opportunity for stewardship. And look at that red box right there. Penicillin VK, our data had shown an average duration of day supply up to 8 days. This is a significant finding because the American Dental Association guideline recommend a shorter 5 to 7 days, and most evidence-based guidelines from the medicine side for any acute uncomplicated infection are not pushing for 5 days or less. So what it's telling us based on our data is we have 2 targets. In addition to reduce high risk of clindamycin use, but we also want to educate our dental colleagues on the guideline concordant and shorter duration of treatment. And doing that, we knew from the start that we could not do this to the dental community. We had to do this with them. So we formed our very first Arizona Dental Antimicrobial Stewardship Ad Hoc Committee, and I am so immensely proud of this collaboration. We brought our academic partner from Midwestern University, from both dental school and pharmacy school, AT2 University, Arizona School of Dentistry and Oral Health, as well as the University of Arizona College of Pharmacy, as well as College of Public Health, to the table with the Arizona Dental Association. So this built immediate trust and credibility because we need the buy-in from our colleague and we need to have those dental champion. And our goals were simple: identify the unique barrier that they find, provide a co-branded trusted education, and increase our outreach, especially to our rural dental clinicians. We deliver targeted education for high priority groups. So this webinar for the Arizona Alliance for Community Health Center. This wasn't a generic stewardship talk. We used our data on prescribing trends. We highlighted prophylaxis guidelines, and we specifically addressed and debunked the outdated myth surrounding clindamycin for patients with penicillin allergy. And this was direct data to action intervention made possible by our interdisciplinary collaboration. And all this work is culminating into a capstone project that we are so thrilled to be launching soon, our dental antibiotic stewardship toolkit. So this will be a comprehensive yet easy to use guide for every dental office in Arizona. It translates the CDC outpatient core elements into a dental-specific context. It discusses the consequences of overuse of antibiotic, but also provide a simple, actionable tools and resources. And the toolkit represents the final step in our data to action pipeline, from identifying the problem as CMS data, building a coalitions, and delivering education. And everything we just showed you so far is our deep dive data analysis from our members in OHI team, as well as our inpatient, outpatient survey, our targeted dental collaborations. This is all built upon the foundational belief that stewardship is a core public health responsibility. So then let's zoom out and talk about public health approach to stewardship and what we have been doing at the Arizona Department of Health Services. To understand our strategy, we first have to understand our landscape. And this map shows the mean distance to an infectious disease specialist. Like many of you, Arizona has a vast ID desert because most of our state is rural. So this map is not a barrier. This is our guidance. This defines our roles. If our provider cannot have access to a local ID specialist, then we at the State Health Department, in collaboration with our local health department and tribal health partner, must step up to be that resources. And we must be the partner, the data analysis, as well as the educational hub for the state. And then I am so incredibly proud to say that this commitment starts from the very top. This is a core priority for our entire department at ADHS. So this is a letter sent to all clinician and public health partners signed by our entire ADHS leadership team, from our medical director to our chief of the Office of Healthcare Associate Infections. It is a public, unequivocal statement that AMR is an urgent public health and that our department is committed to this work and supporting our partner and to leading the statewide collaborative. And this top-down commitment is our bedrock, and this is what the action can look like. And ADHS has been so proud that we continue to fund high-value resources for our Pacific partner. And we continue our collaboration with the University of Arizona Center for Rural Health to provide free membership to our critical access hospital, to the University of Washington Center for Stewardship in Medicines. This is a perfect example of targeting our education resources to support our rural and critical access partner. And it is about us ensuring that everyone has the support that they need. We meet our partner where they are. We are not just a regulatory body, we are also a colleague in the healthcare setting. Our stewardship team is out there actively presenting and engaging at the Arizona Infectious Disease Society. We're in lecture halls. We are providing continuing education at professional conferences, and we are hosting webinars for hundreds of partners across our state. And we take our data, as we show you, turn into actionable and evidence-based education for a specific partner who need it. So this will build trust, build capacity, and is build a unified statewide messages. Okay, so that's a lot on provider education. So let's switch a little bit to talk on the other side of the coin of public health outreach, right? If we only education provider, we're only solving half of the problem. We must also education our patient, educate the public. But let's be honest, it is hard. Antimicrobial resistance or AMR is definitely has a language problem, is often perceived as a distant issue, doesn't have good engagement from the public. And sometimes our messages, if we're not careful, can be a little bit confusing or even punitive on the essence. So we have to be very, very smart about how we talk about this and approach our public. So this is our playbook. This is how to approach the issue. So first, our team, we try to frame AMR as something that undermines all the modern medicine. It not just simply a stat, not just infection, not just outbreak, but also the life-saving medication for the successful C-sections, a safe chemotherapy infusion, and routine joint replacement, so that we can make it personal for our public. And as well, our tone to be supportive and solution focused. When we say don't do this, and we have to provide what is the alternative solution to that. But we must also focusing on encouraging immediate, simple actions like hand hygiene and also vaccination, which are all part of infection control. So we can see that we collaborate with our state communication team to get these messages out on all our social media platform. We can see we're taking about C. diff, we see about virus bacteria, and we're also framing AMR as what it is, a one health global crisis that affects us all. And we're working to normalize the conversation to the public. When we as ADHS, we are not stopping at the static post because we are all overachiever. We're using video, we're putting our own vet team member, our ID pharmacists, our ID physicians, our epidemiologists, clinical microbiologists, as well as our office chief and program managers on camera for the Antibiotic Awareness Week to create this short, shareable content that put a human face on the complex topic. And to put a plug, our content is going to schedule it to be posted throughout the week. So please help us share and raise awareness about this video to help reach for the public. And all of this work, professional and public, culminate into our biggest event of the year, the U.S. Antibiotic Awareness Week. And we are so proud to show you that our official state proclamations signed by our Governor Katie Hobbs for 3 consecutive years. This is a powerful symbol of our state long-term commitment and is a banner under which all of our other partners can rally. And because our job at the state is to empower our local partner, and we provide data, toolkit, and we also provide the collaborations. And we are so proud of our partners such as Maricopa County, our state largest county, to take that and run and participate during this year Antibiotic Awareness Week. We are here to amplify and show off all this amazing work so that they can use their trusted local voice to deliver provider letters, public-facing resources directly to the community. And we see the exact same thing with our partner in Pima County. This is home to our Tucson city, which is the second largest city in the state. We take the theme fighting antimicrobial resistance takes all of us, and they make it local. They issue their own proclamation. They create their own press release. And this is a model that we have built in Arizona, that we are a collaborative state. And as our leadership has made it clear, we are fully committed to get with our partner for this fight. All right, so that is a lot to cover, but hang with me. So we're gonna take a quick summary on what we have covered so far. So in here, as a summary, ADHS is taking steps to promote appropriate antibiotic use through multiple prongs. We providing educational session, creating toolkits, building the collaboration with our local health department as well as professional organizations, and we serve as a resources for our antimicrobial stewardship and resistance questions. And here is the resources for those who are tech savvy in our audience. Please be welcome to take out your phone and scan this QR code. It will take you directly to our ADHS Antimicrobial Stewardship Community website, and we have all materials in there. We have our antibiotic awareness material, our toolkits, our office hour recording that Kelly mentioned earlier. Then they're all there for you. And we also include links for our key CDC resources that we build upon, and most importantly, our team direct email. And I want to end our conversation, these presentations on this. This the slogan "Fighting AMR takes all of us" is not just a catchphrase we use for a poster. In Arizona, it is our core philosophy. And this right here, this is us. This is the Office of Healthcare Associate Infection at ADHS team. We have our epidemiologist, we have our pharmacist, we have a physician, infection preventionist, a clinical microbiologist from the Arizona State Public Health, and program manager, medical director, you name it. And I am so incredibly, immensely proud to be part of this team. And on behalf of them, we would like to thank you for your time, for your partnership, and for all the work that you do in this fight. So thank you. And with that, I'm open for any question anyone might have.
Thank you, Dr. Pham and Dr. Klonsberg. We do have one question in the chat. Let me share my screen first. Okay. Why do you think dentists have not gotten on board with antibiotic stewardship as much as the other medical providers, other than what you mentioned about needing help developing an antibiotic strategy? We hear from providers about the pressure from patients, and that makes me think how can we help educate the patients? Sometimes we need to meet people where they are, and maybe we do something viral that will make the antibiotic stewardship fun and engaging. We learned during COVID how important speaking to your audience in an interesting way was much better than our typical bland way. So what do you think about how we reach dentists, and is it different than all other specialties you showed in your graph? They all seemed more tightly bound.
Well, that's a good question. Thank you for asking that. I think this is like a really good question that we always want to be very mindful on how we approach our dental colleagues, because like even myself, like we have a couple of my close friends also a dentist and own a private practices, and they always tell me that like from their perspective, but they say, "To, I want to do the right thing, but at the same time, I got stuck in the middle when I have different provider, either the orthopedics, the cardiologist, that tell my patient that they need to have an antibiotic, and then when they come to me and they say, I'm just a dentist. So now I'm in the essence, they are forced to doing that. So that's why we have been actively working and engaging with our two dental school locally in Arizona so that we can find a way and so that we can have more of the education session for our dental trainees to build that confidence that they have. And one of the goals that we have with that dental ad hoc committee that we have is to potentially get more involvement from outside of the dentistry, like maybe some orthopedic, some of the cardiologists, because they are those two main driver. Well, the prophylaxis for infective endocarditis and pulmonary infection are the two main driver for antibiotic use in dentistry.
I'd also like to call out all the work that the Association for Dental Safety is doing around antimicrobial stewardship in dentistry. They started holding annual conferences, webinars throughout the year. So there's a really concerted effort from their group to improve antimicrobial stewardship as well. And something else that I think To briefly touched on, but just to emphasize, is that we're working with the dental programs to get into the classroom before graduation to talk more about antimicrobial stewardship as well. And although that is already a component of their curriculum, we're going to be adding to that, which hopefully with, new waves of practitioners coming out, that's always the hope that they're up to date on current practices and recommendations. So thank you for that question.
Thank you, Dr. Pham and Kronsberg. I do have one question from my side. So what are some of the things that Arizona Department of Health Services doing to support smaller rural or resource limited facilities in building or strengthening the antimicrobial stewardship programs in those facilities?
Are we talking about, so I'm going to touch on the outpatients and then I'll defer to my amazing colleague here to talk about the inpatient side. So for the outpatient side, like when we did our outpatient survey, we did ask if we did leave an option for our facility if they want to leave an email, a contact, so that we can follow with them and offer support when we can. And so far, like we are in, things are in motion to potentially form an additional ad hoc committee to focus mostly on outpatients, and with the rural facility being one of our top priorities, because we're also very aware of that as well.
Yeah, and from a more general or inpatient standpoint, all of our meetings as well as webinars such as today are conducted virtually so that attendance is not a barrier for any of our rural partners. That's something that we want to make sure is in place. And then, as Toe touched upon, partnering with the University of Arizona Center for Rural Health so that those critical access hospitals have access to the University of Washington Center for Stewardship and Medicine, which meets weekly to discuss antimicrobial stewardship. Those facilities can pose questions or have additional resource access there beyond just what we're providing at the state. So that's something that we've been working on to provide additional resources and support to our rural hospitals.